our next speaker, I'm very happy, very proud to introduce an eminent, exceptional gastroenterologist and endoscopist, Dr. Ahmed Hashim. Dr. Ahmed Hashim is a consultant of gastroenterology and hepatology at Al Habib Center. He was graduated from Kuwait University and received his advanced endoscopy training in Canada. He will speak about management of refractory and large CVD stone or biliary stone. Please, Dr. Ahmed.
Thank you very much, Dr. Omar. I'd like to start by thanking the organizing committee in KGA for the lovely invitation. Also to thank the audience for their patience until this time. Remember, after this lecture is the quiz, the prizes, and a good lunch, hopefully. So today we're discussing the management of refractory and large CVD stones. I have nothing to disclose. To make this talk probably more interesting, I thought to discuss 3 cases that I came across recently. The first case is a 59-year-old male. He's healthy. He was actually referred from another center where he underwent an ERCP and laparoscopic cholecystectomy for removing multiple CVD stones. So the endoscopist at that time, he found a very dilated CVD, removed 2 small stones, and then he wasn't sure of complete clearance of the bile duct, so he decided to place a stent and to bring the patient back on another session of ERCP. So if you look at the images here, the first image on the left side, this is the primary RCP, where you can see the endoscopist found a very dilated CVD, but there was no clear stone. Probably 2 small stones were removed, so that's why he decided to place a stent. And when bringing the patient back after the cholecystectomy, he was surprised with a large stone in the proximal part of the common hepatic duct, and a smaller caliber at the distal part of the CVD. So that's when he was referred to our center for further management. The second case is a 46-year-old admitted with picture of cholangitis. So he came in with high-grade fever, abdominal pain, jaundice. His cholestatic picture is quite high. His bilirubin is more than 350. Ultrasound showed multiple gallbladder stones and dilated CVD, so he underwent an emergency ERCP. And this is the cholangiogram that we found during the ERCP. So you can see 2 large stones, very dilated CVD, I would say up to 2 centimeter CVD, and probably we should discuss the management of that case. And the third and final case is a 39-year-old. He came from the Philippines, and we reviewed his chart, and actually he underwent many ERCPs. In our center, we counted more than 10 ERCPs, and most of the ERCPs reported large stones have been removed from the bile duct, common hepatic duct, intrahepatic ducts. Eventually, he was labeled of possible oriental cholangiopathy. He underwent hepaticojejunostomy in 2016, possible lobectomy. The surgical notes were not very clear. And then he disappeared from 2016 until 2024 when he came back with picture of ascending cholangitis, and he underwent an emergency PTC placement because of his altered anatomy and because of picture of unstable cholangitis. So this is a picture of the PTC. So the radiologist had to go from the left side of the patient and go through the bile duct, and this is the cholangiogram. Probably some parts of the bile ducts were not very well visualized, so he was stabilized, his LFTs came down, eventually normalized, and then he underwent an MRCP, which showing multiple filling defects, mainly in the right posterior lobe of the liver. So this is, again, an altered anatomy and difficult position of the scopes of these stones. So to discuss choledocholithiasis, globally, it's the most common cause of biliary obstruction. About 10 to 20% of the patients with gallbladder stones, they have choledocholithiasis. 3 to 10% of them, 3 to 10% of patients undergoing cholecystectomy, they have concomitant choledocholithiasis. In the USA, 10% of patients with symptomatic choledocholithiasis have concomitant choledocholithiasis. 70%, interestingly, are Native Americans, and 10 to 20% also they have concomitant choledocholithiasis. The higher the age, the more likely they develop choledocholithiasis. And large stones have been classically defined in most of the literature as stones more than 1.5 centimeter, in some other literature more than 1 centimeter. Now remember, 90%, maybe 80 to 90% of the stones can be removed by classic ERCP, including sphincterotomy, as simple balloon sweeping. And today we're discussing the other 20%, which are difficult stones. So again, we go back to basics. How do you look for choledocholithiasis? History and physical exam. Basic labs, including CBC, liver enzymes, coag, and pancreatic enzymes. We start with an ultrasound. We look for the probability of choledocholitis. And sometimes, if the probability is intermediate to low, we have to undergo sometimes CT scan or an MRCP, and occasionally an endoscopic ultrasound, especially in intermediate probability of choledocholitis. Sometimes it's not a standard of care, but sometimes we might have to jump into our colleagues in radiology department to undergo PTC and cholangiogram. And sometimes, especially with a low probability of choledocholitis, the surgeons takes the patient for cholecystectomy, and incidentally, they found choledocholitis during intraoperative cholangiogram. Sometimes intraoperative ultrasound can diagnose this as well. So what is a difficult stone? What is refractory stones or difficult stones? Stones that are difficult to be removed by classic ERCPs. So stones that are larger than 1.5 centimeter, multiple stones, especially if multiple large stones, difficult location, impacted stones, proximal to a stricture site, or intrahepatic stones. If you see this, I think every advanced endoscopist, if you see these three factors, he anticipates a difficult ERCP. At the same time, now we're encountering more and more altered anatomy, post-bariatric surgery, and this needs a whole dedicated talk that I don't think I'm allowed to undergo these details today. Angled CBD and diverticulum, patient's age, condition, instability, severe cholangitis, all these factors are considered high-risk factors for difficult CBD stones. So management, I just wanted to highlight sometimes doing nothing is also part of the management depending on the clinical scenario that I'm not going into the details today. But mainly we're focusing today on the endoscopic part of management of difficult CBD stones. So remember, there is emergent and non-emergent part of CBD stones management. Today we're focusing on the non-emergent part. The emergency parts is also another aspect and talk. So in the non-emergent ERCPs, we use balloons, baskets, lithotripsy, including the intercorporeal EHL or laser lithotripsy, or extracorporeal shockwave lithotripsy. They're always surgical options and percutaneous options as well. So if we start with the straightforward, simple methods, including the ERCP with simple sphincterotomy, again, that's in 80 to 90% of the cases, this should be successful. And then we go and we use more and more ERCP with sphincterotomy plus large balloon dilatation. So I think Dr. Cole, he went through these steps with a simple ERCP. So we identify the major papilla, we cannulate using the sphincterotome over a guide wire, we advance the guide wire deeply into the bile ducts, and then if you find a native duct, we perform sphincterotomy. We exchange the sphincterotome, and we continue instrumentation over the guide wire, and this is the case in classic ERCPs. So stone extraction, in the standard classic ERCPs, we used classic sphincterotomy and then balloon sweeping. This should be, again, successful in up to 80 to 90% of the cases. And then we have the ERCP, sphincterotomy, and large balloon dilatation. Now, I think every endoscopist has to be careful on the size of the balloon dilatation that we're using, because he has to assess the diameter of the bile duct in comparison to the balloon size that you are using. You always have to go to a size of the balloon that's equal or less to the distal bile duct. You cannot go more than the size of the bile duct because you're always putting a risk of perforation. Also, you have to be very careful assessing where is the stone, because if the stone is trapped between the balloon and the wall of the bile duct, also you're putting the patient under risk of perforation. So these factors will make a difference when you decide to do a large balloon dilatation. So is there data behind it? Yes, because the American and the European guidelines came up with the data that support this evidence. If we start with the American Society of Gastroenterology guidelines, they recommended management of CBD stones based on the systemic review and meta-analysis to overcome endoscopic papillary large balloon dilatation versus only sphincterotomy. Is there a data supporting it? So they reviewed more than 4,000 abstracts. The average stone size was between 10 to 15 millimeters, so large stones, and the average balloon size was between 15 to 20 millimeters, which is quite a large size of the balloon. 9 randomized controlled trials comparing the sphincterotomy plus large balloon dilatation versus, on the other hand, only sphincterotomy. So again, we're comparing sphincterotomy large balloon. The other side is only sphincterotomy. 500 patients in the large balloon dilatation versus 550 patients in the sphincterotomy alone. So they came up with the conclusion is that the sphincterotomy plus large balloon dilatation are more likely to complete clearance of the large stones versus sphincterotomy alone. So this is the first line management of large CBD stones is sphincterotomy plus large balloon dilatation. Any adverse events? It's not a difference. It's not different from standard ERCP. So they looked at the complications, including cholangitis, bleeding, perforation, and pancreatitis. Both groups have similar non-significant difference in terms of complications. What about the Europeans? So the ESGE also, they published their own guidelines based on the data they have. So endoscopic sphincterotomy versus balloon dilatation versus combination of both. So 3 arms. The primary endpoint was complete stone clearance rate on the index ERCP, and the secondary endpoint, again, we're looking for the use of other methods, including the mechanical lithotripsy, and they looked at the adverse events as well. So they were able to find 16 studies, more than 2,500 patients, and they came up with a similar conclusion to the American Society of Gastroenterology guidelines. So complete clearance of the stones was significantly higher in the combined group compared to the sphincterotomy group, lower need for mechanical lithotripsy, and no difference in terms of side effects, and they included all kinds of adverse events, the pancreatitis, bleeding, perforation, cholecystitis, and even stone recurrence. There was no significant difference in terms of adverse events, but there is a huge difference in terms of clearance of the stones. So again, sphincterotomy plus balloon dilatation is your way to go as first-line treatment. So this is a picture showing an MRCP with a large filling defect in the distal CBD. I'm sorry, the cursor is not working very well. So they used a large balloon dilatation of the distal bile duct to try to extract. And if you notice, the stone is in the distal bile duct, but during dilatation, the stone moved up. So they did not entrap the balloon with the stone because risk of perforation, and then eventually you should be able to completely clear the stone. So ESG guidelines, they recommended that patients with large CBD stones to undergo sphincterotomy combined with endoscopic large balloon dilatation as a first-line approach to difficult CBD stones. And then second line, they recommended mechanical lithotripsy when the sphincterotomy and large balloon dilatation failed. And then a third line, or considered as a second versus third line treatment, is the use of cholangioscopy-assisted intraluminal lithotripsy, whether it's an EHL, electrohydraulic lithotripsy, or laser, as an effective and safe treatment for difficult bile duct stones management, and all based on strong recommendations. So let's talk about baskets. Baskets is one of the frequent tools that we use during ERCPs. As we know, there are different shapes, different sizes, wire-guided or not, and each one is different in terms of radial force to remove the stones. And then sometimes we are forced to use mechanical lithotripsy, and they are used after failed endoscopic sphincterotomy, balloon dilatation, or even a basket. And sometimes we have a salvage treatment, including the Sohandra lithotripter or mechanical lithotripters as well. And then we come up with the latest technology, which is the cholangioscopy-assisted EHL, electrohydraulic lithotripsy, or EHL assisted laser treatment. So this is successful in the literature, reported more than 99%, probably up to 99% clearance rate of the stones, which is quite a perfect tool to use during ERCP. So the advantage of the cholangioscope is the direct visualization of the bile duct, stone fragmentation using the probe with electrode fibers, and it has a preset voltage or wattage with consecutive pulses. And the only thing you need is antibiotics prior to the procedure and to hold anticoagulation. So if we go into the details of the cholangioscope, so we advance the cholangioscope through the duodenoscope into the bile duct for direct visualization, and then we advance the EHL probe through the cholangioscope, through the duodenoscope, into the bile duct for direct visualization. So we look at the stone, we get close to it without touching it, so this is a non-contact technology, and the probe with the electrodes creates a high voltage spark in short pulses. The medium has to be normal saline around the media to proper generate the high voltage sparks, and then it generates pressure and fragments the stone. That's the idea behind it. Adverse events, quite rare, but it's been reported in the literature. So it's quite standard complications compared to ERCP. 1% risk of direct bile duct injury, perforation and bleeding, or incomplete stone extraction, and these are quite low complication rates. So evidence-based approach to difficult CBD stones. So you encounter a patient with CBD stones, and then the endoscopist will anticipate difficulty based on the characteristics of the stones. So if the stones are easy, you proceed with the classic ERCP, sphincterotomy, and sweeping balloon. If the endoscopist encountered a difficult ERCP, including large, more than 1.5 centimeter stone, narrow distal CBD, angled CBD, or multiple stones, then he proceed to the next step, which is sphincterotomy plus large balloon dilatation as the first-line treatment. If you were unsuccessful or inappropriate, then you proceed for either mechanical lithotripsy or cholangioscopy-assisted removal of the stone. Again, this should be successful in up to 99% of the time. However, sometimes it's inappropriate, or you don't have the accessories, or you don't have the tools to clear the stones. That's when you can place a stent and either refer a patient to a tertiary center or try again on another session. So if we go back to our cases, now remember, this patient, he underwent ERCP in another center. They found a large stone, but if you notice, the caliber of the distal CBD is not as large as the stone. So by guidelines, we should proceed for cholangioscopy-assisted INT'L, and this is what we did. So this is the cholangioscopy that we use. So the device can go directly inside the bile duct. We can directly visualize the stone. Actually, there are multiple stones. And then we advance the INT'L probe to directly apply a non-contact INT'L voltage pulses in order to break the stone. This is a large stone, so this took some time, quite some time, but eventually we were able to completely clear the bile duct. So you can see that with this technology, we're able to directly look at the pathology and directly deal with it. And eventually, after the clearance of the stones, we were able to remove all the fragments successfully. And then with the next case, so he came in with acute cholangitis, and the stones were quite large in the distal bile duct. So in the setting of acute cholangitis, unstable patient, try not to completely clear the bile duct because it needs some instrumentations, needs some time. And in case of unstable patients, we didn't go through that today, but in case of emergent ERCP, try only to place the stent, decompress the system, manage the cholangitis, and then bring the patient again. But this is also a patient who's perfect candidate for sphincterotomy plus large balloon dilatation to completely clear the stones. And then the third case, which is a bit more challenging because, remember, he had many ERCPs. He had altered anatomy. He has hepatojejunostomy. And then he underwent a PTC. And the PTC is, if you notice here, he has multiple stones in a difficult segment of the liver, so right posterior lobe of the liver, which is quite a difficult access. Even for a radiologist to access with a PTC, it's quite a difficult segment. So after discussion with the team, so it's important for you to always discuss these difficult cases with your colleagues in surgery, hepatobiliary surgeon, and colleagues in the interventional radiology and ourselves advanced endoscopists. So we decided to go with a cholangioscopy-assisted lithotripsy. So look at the PTC images first. So if you look at this image, so they're doing a cholangiogram, but there is very poor localization or maybe assessment of the right posterior lobe of the liver. And with further contrast injection, you can see multiple filling defects actually in the right posterior lobe. So multiple stones in the right posterior lobe and the proximal part of the posterior lobe as well. So that's why when the radiologist helps advancing the cholangioscope through the guide wire, through the PTC axis, and goes into the right posterior lobe directly, where we can perform an INT'L lithotripsy and completely clear the duct. So you can see here the difference between the first image and second. So this is the cholangioscope going through the same axis and clearing multiple stones in here. And actually you can see a quite significant clearance of the right posterior lobe after successful cholangioscopy. So this is a video just to show you the setting of collaboration between the gastroenterologist and the interventional radiologist. So the screen is on the right side of the patient, and we're directly looking at the bile stone. Again, remember, this is a percutaneous axis of the cholangioscope. We're doing INT'L, we're breaking the stones, and the radiologist and the gastroenterologist are on the left side of the patient. And with this collaboration, we were completely successful in removing all the stones from the right duct of the posterior lobe of the liver. Let's make it faster. So the take-home message from today's cases is multidisciplinary teamwork is of key importance. Procedure selection is based on the expertise and availability of the accessories. It's important to carefully assess the stone size relative to the size of the sphincterotomy and distal CBD. The stones can generally be removed using the standard tools, including sphincterotomy and ballooned, sweeping balloon. Now remember, in difficult CBD stones, sphincterotomy plus large balloon dilatation is always your first-line tool. And again, its success rate is more than 90%. Mechanical lithotripsy is the second-line treatment if the first line fails. And then eventually you have a cholangioscopy, which can be considered also a second-line treatment in case of failure of the first-line treatment or inappropriate first-line treatment, which is quite safe and effective. And CBD stones in altered anatomy is a whole new talk, and it's quite challenging, but it's revolving these days. Thank you very much.